Good day, friends, and a warm welcome to the 44th episode of 4D Detailed Discussion and Dialogue in Diabetes in Indian Diabetes. We speak about various aspects of diabetes and diabetes care, and you see that we have gone out of the box. We've gone beyond the confines of what you'd say is conventional thinking or traditional thinking. And this has helped us enhance our learning, enhance the quality of the way in which we treat diabetes. Today, we have an expert with us, somebody who will talk to us about how you treat diabetes, how you approach diabetes in women. Now, women, it is said, hold up half the sky, but I think they hold up more than half the sky. And this is also true for our guest, Dr. Vandana RK from Bangalore, who does much more than her fair share of managing diabetes. Working at the Cure Diabetes Center in Bangalore, in the heart of old Bangalore, she not only focuses on clinical care, she also works on public health, digital technology, digital awareness, and research. And that's why we say Dr. Vandana holds up much more than half the sky when it comes to diabetes care. A warm welcome to you, madam, and we look forward to learning from you about diabetes, especially diabetes in women. What is the pathogenesis? What are the promoting factors, the etiologic factors? How the investigations are different, how the management is slightly different, and how we need to tweak our care to ensure that the women of our country, the girls of our country, get the best possible treatment for diabetes. Welcome, madam, and the stage is yours.
Good morning. I'm Dr. Vandana, consultant diabetologist and physician practicing at Cure Diabetes Center, Vijayanagar, Bangalore. Today, I would like to thank Sun Pharma for giving me this opportunity to share my ideas and thoughts on women and diabetes. So, can you just please share the slides? Yeah. So, the reason why I have picked up women and diabetes is this is one of the fields wherein it is most neglected, especially in our countries. So, whenever we give importance to that, be it any aspect with the male counterpart, the female counterparts are a little neglected, or rather, I would say, taken for granted. The reason being the culture and heritage, how our country comes from. So that is the reason I selected this particular topic. So to emphasize on how even the women health becomes important. And apart from that, before I begin my presentation, I would like to request all the practicing physicians to screen all the counterparts, women or the spouses who accompany a male diabetic patient to your clinic. Just screen them once for diabetes and hypertension so that at least 20 to 30% of undetected cases can be picked up here. So the reason why this thing has been picked up is diabetes, as we all know, is a silent killer. Why do we call it a silent killer? Excuse me. The reason is most of the people with diabetes have uncontrolled sugars. They run for years together without getting it checked, or even when they're getting it checked, they just don't go for the regular follow-ups. And when all these happens, there is the autonomic symptoms which sets in, and that will start deteriorating or reducing the number of symptoms you start seeing. Say, for example, thirst, hungerness, loss of weight. All of these things will not be seen when the blood sugars are really too high. So that is the reason we call it a silent killer. And now, why emphasize on women? Because the the biological makeup of a woman is totally different from that as a men. And another reason why we have to emphasize on women is whenever there is, when you take both the proportion, men and women are at the higher risk of developing heart diseases as compared to men. And when we come to the outcome of the cardiac disorders, even that is worst in women as compared to men. And secondly, by the time when we diagnose the women with diabetes or start treating her, or when they walk into the clinic, already most of the complications would have been set in, be it retinopathy, which comes as blindness, or nephropathy, which comes as pedal edema, or even for to some extent, people even come up with psychological complaints like depression. Reason being the amount of attention given to them in the Indian society is very less. Say, for example, a male counterpart of a family, excuse, whenever a male member of the family even just falls sick with a simple fever, the amount of attention given to them is much more than a female counterpart. And the reason why, there are a number of studies which says more women are affected with diabetes as compared to men. So in this study, it says that by 2040, there'll be around 313 million of women with diabetes. And the main concern is all women should get the equal amount of care and treatment which what the other counterpart is getting, and they should be even accessible to all the diabetic medications as such. So as we had already discussed, so women are more prone. And another thing is, whenever there is a woman with type 1 diabetes and not treated and not taken care properly, there is a large chances of she having a miscarriage, or the baby is born with malfunctions or mal syndromes. These are a lot. So now it is not that the women doesn't know what has to be done. They know, and they are very what say reluctant to go take the treatment. So when we see at the numbers, 85% of the women agree that diabetes requires regular follow up, regular medication changes for them to prevent or keep that under control, but still that is not followed. And out of which 50% of them, they don't even go and get themselves checked. For this, I can just give you an example. In the OPD, in my OPD, when people come in, and if there is a woman who is an attender, I just ask her to get screened herself for diabetes. Say, for example, just like a random screening, she would be aged more than 40 years, or there would be a family history of diabetes, something like that. So when I ask, they really are very reluctant to get it checked. The sole reason and the answer I get is, if they get checked, they'll get to know that they have diabetes and they don't want to get it checked. This is the mindset which has to be worked upon. And there are 50% of the people who believe that exercise and yoga are beneficial in controlling diabetes, but still they don't do it. And few also agree that exercise forms an important aspect in management. And uh, and I wouldn't say 35% of the population, most of them, they are, rather than consulting the physicians or diabetologists whenever they are detected with diabetes, they go with Google, they go with YouTubes, and they go with their friends. And finally, they end up getting complications. And the lack of management, I would say, is definitely more. And it need not be only in, what say, a rural part or metropolitan cities. Either ways, it is the same. Even in metropolitan cities, the education level about the diseases is same as compared to the rural areas. And 60% of the Indian women are aware of diabetes linked to their pregnancy, which is gestational, after which they are even advised to get their sugar checked at 6 weeks and 6 months, most of which are reluctant to get it done. And many of them know pre-diabetes will get converted to diabetes, and they're supposed to make some lifestyle and dietary choices. Couple of them make, and few of them just take it for granted. And 70% of the women also acknowledge that regular meals and regular exercise is important for healthy body. And 60% of them confess to skipping meals, and they attribute this to their daily routines. Get the kids ready, get the husband ready, send them off, and by the time they sit there for the breakfast, it will easily be 11:30. And 20% of them say eating habits are irregular. So type 2 diabetes is the most prevalent form of disease, and the women comprise the largest affected groups. And coming to gestational diabetes, it occurs in 2 to 7% of all the pregnancies. And this again varies according to the racial and ethnic groups. And even the family history also plays an important role here. Most women return to the normal glucose tolerance after delivery, but again, a few of them will continue. In this view, most of them do not even get their sugars checked at 6 weeks and 6 months. So, which has led to gestational diabetes being referred to as a temporary conditions. They're not even in a status of mind to accept that this can further go ahead and it can develop into diabetes. No, it was during pregnancy, I've delivered and I don't have diabetes. This is another reason for most of the women to land up in diabetes. Diabetes can remain undetected for many years, as long as in half to three-fourths of the cases. Some individuals with type 2 diabetes exhibit very few or less symptoms, but Off late, because of the lifestyle, the the MNC cultures, most of them, they don't even have time to think that they would be going through the symptoms, but they don't even have to time to think about what it is. The long-term consequences or damage from having prolonged elevated blood glucose can be significant even before the diagnosis is made. As I told, they come with blindness, pedal edema, or burning sensation in the foot. So this is like the widespread disease in middle-aged or the older women. So this many areas are included in this. Once that is not diabetes is not checked and brought under control, this can lead to a multi-specialty complications for a woman, be it cardiovascular, mental health issues, repeated infections, contraception, infertility. All these things can finally pose a bigger problem when one simple non-communicable disease is not detected and treated. Postmenopausal women who have a combination of risk factors, but that includes diabetes and overweight, are at particularly high risk for mortality and morbidity from cardiac disorders. Finally, coming to the expenses, this plays a crucial and an important role in management of diabetes in our country. Average individual has health costs that is 2 to 5 times higher than that with a person of diabetes. And medications, they say once you get to know you're a diabetic, then that has to go for lifetime, multiple visits to the hospital, and most likely to require a placement in the long-term care facility. Um, then emotional costs. Immeasurable diabetes may have a greater impact on quality of life than other chronic diabetes because diabetes management is an integral component of daily living. So what happens that much amount of support from the family members is required, especially in Indian household. What happens is when we advise some kind of dietary changes or dietary modifications for a woman, she just looks into and caters to the whole family's needs and finally forgets what exactly she is in need for treating her diabetes. One of the study found that women with chronic conditions who self-report poor adjustments have fewer social and psychological resources to draw upon to cope with their chronic illness. So exactly. So when there is a woman who's taking care of somebody who's chronically ill, her health status is not at all cared for. And imagine if she is the one with that chronic illness, then the care and concern should be more, which is not given. So now what are the therapeutic strategies which we can follow for this? So in diabetes, the ultimate thing which has to be followed is diet and exercise. That has to be given priority, followed by which there are a couple of drugs like DPP-4 inhibitors, SGLT2 inhibitors, then GLP-1 analogs. All this can be given. So early initiation of combination therapy. Now what we say when we go with the age-old methods, I start with metformin, then I give with sulfonylureas and come. Especially in Indian household, when there is no strict following of timings, when you give sulfonylureas, there are chances of hypoglycemia. So, with the newer combinations with lower side effects and lesser hypoglycemic symptoms, combination therapy will definitely help patients to achieve better glycemic control. So, for example, when you combine metformin with an SGLT2, that provides apart from diabetic control, no risk of hypoglycemia. There will be a little weight loss for the patient. Cardiovascular and renal complications are also taken care to some extent. So why SGLT2 and DPP4 is like a suitable option for us? Safer, rapid, and sustained glycemic control. As I told you, lower hypoglycemic effects improves both resistance of insulin and the beta cell functions, helps to reduce body weight and blood pressure to some extent. So all this, when the blood pressure is reduced, body weight is reduced, this contributes to the overall well-being of the patients. And the best option of this, the benefit of this is it reduces the pill burden. Say for example, when you say give one sulfonylurea, one metformin, one DPP4, compliance would be worst. So when the combination is together, the pill burden is reduced and the compliance is better, and overall the cost effectiveness. So with this, I would like to come to an end of my presentation. And here again, I would like to reiterate everyone, please screen the attendees, be it male or female, whenever they walk into the OPDs, because there are a lot of undetected patients walking around with high blood sugars without any knowledge that they have diabetes. So you can contribute this way for a healthy society.
Thank you, madam, for that wonderful talk. Now, insulin will be the same in girls with diabetes and in boys with diabetes. But adolescents, especially girls, they have other issues to look at. So, let's say a girl comes to us with dysmenorrhea, or she comes to us with premenstrual syndrome. Will this impact diabetes care? And what should we do? How should we approach a girl with menstrual disturbances? In terms of how should we approach her in terms of glycemic control and supportive therapy?
Yes, thank you for the question. So it depends on the age with which the girl presents. Again, the adolescent girl with dysmenorrhea or any kind of menstrual symptoms. Again, this forms a cascade with the metabolic syndrome. So here, what I would say is a couple of investigation would definitely help us. Somebody who comes with menstrual disturbances, adolescents, in today's practice, we see a lot of PCOD cases. So that in that case, we'll have to look into the insulin resistance, how it is, then the physical build of the patient. Once most of them who come with this menstrual disturbances or irregularities, insulin resistance would be the cause, which is preceded by PCOS. So manage on the initially I would say we should work on the weight management of the patient, because in these patients when we look at the physical signs, most of them will present to us with overweight and signs of insulin resistance like acanthosis nigricans. So in these scenarios, I would say we would just work on the weight management initially, and then that brings down the insulin resistance, which helps us in our management.
Thank you so much, madam, for that. Let's come to the first question. And this is based upon your experience in Bangalore, in Karnataka. Do you feel that women have more diabetes, girl children have more diabetes, or is the gender ratio the same? Is it just a 1-to-1 ratio?
No, because initially when I started my practice, I was in the same mindset that again men would have more percentage of diabetes as compared to women. But as I started my practice and I started looking into it, the percentage of women who have diabetes is equal to as with men, or I would say a little higher. I would give 1% more to women. But the thing is, they are not getting screened or checked for diabetes. And this, I came into a conclusion when I ran a diabetes campaign in the month of February and March in Bangalore. So I went around screening random patients on every weekends, and that is when I got to know female population. Firstly, they are very reluctant to get it checked, and after convincing them and whatever we check, most of them have diabetes who are unaware. So education will play an important role, and women have equal, or I would even say a person more than men.
Thank you so much, madam, for that. So the question, madam, is during pregnancy and before pregnancy, what are the drugs of choice that we should use? And what are the drugs that are a big no-no, which should be contraindicated totally in women who are planning pregnancy or who are antenatal?
Okay, so again, it depends. For somebody who is type 1 diabetes, there's no option insulin, we just go ahead with the insulin. Or somebody who is type 2 diabetes, well under control, the only option, as far as I have seen in my practice, is metformin can be given safely. And apart from that, I don't see any other oral drugs is safe to be prescribed. And people who are compliant with their diet and exercise, we can just continue with metformin. If not, as the trimester increases and the glycemic variability changes, shift them to insulin.
Thank you, ma'am. Two more questions, madam, if you allow. And this question is, in lactation, is it necessary that I should give only insulin or can I use oral drugs? Are they safe for the baby, for the breastfeeding baby?
Yeah. So then what happens is, again, to be on the safer side, insulin would be the better option rather than oral drugs.
Thank you, ma'am. And last question coming from the audience is, of course, lots of praise and appreciation for the way you handled this. And we thank you, madam, for leading the fight against diabetes from the front. The last question from the audience is about menopause. So, madam, at the time of menopause, any special things we must keep in mind? Any investigations, any treatment? any drugs that are relatively contraindicated, any drugs that are to be used more proactively in women living with diabetes.
Again, I wouldn't say there are, with menopause, I would always say any drugs which will cause hypoglycemia should be kept at bay. For example, be it sulfonylureas for that matter. Because of the hormonal disturbances, as we have seen, the timings with the food and the intake is kind of not balancing. So keeping sulfonylureas at bay would definitely help. And prescribing drugs which is hypoglycemia neutral, which doesn't have risk of hypoglycemia, is always advisable, like an SGLT2 and DPP4 inhibitor combination, or along with metformin, that should work.
Thank you so much, Dr. Vandana. I'd like to thank everyone who has logged in today. 4D detailed discussion with diabetes. Detailed discussion on diabetes, on Indian diabetes. I've been a part of this program now for so many months. But the more and more I interact with everyone and with our expert speakers, the more and more happy I feel, the more and more confident I feel that Indian diabetes care is in safe hands. Thank you, Dr. Vanna, for having shared your expertise with us. We salute you and all the hard work that you're doing for everyone in India, not only women, but men as well. Thank you and Jai Hind, madam.